Ewen has joined us, and take a breath, Ewen, as you come down. Ewen is a consultant adult upper gastrointestinal surgeon. We mentioned earlier this morning about when our patients reach 18, we then have the issues of transition. And as Matthew pointed out, Mr. Kelly pointed out, getting adult surgical specialists, or indeed adult medical specialists, interested in our patients that we've invested heavily in for almost 18 years can be a challenge. But there are the few exceptional surgeons out there who are interested in our special patients as they reach adult years. And I guess Ewen is, I hope, going to sort of highlight you the sorts of things that he deals with in his practice that are relevant to adult patients with esophageal atresia. So Ewen, you're very welcome, and we'll take questions at the end when Cameron and Ewen can join us behind the table.
This is an adult perspective. I'm an adult surgeon, and I work at the Queen Elizabeth Hospital. And this is the background of what I'm going to talk about, really. A bit about who I am, a bit about the anatomy of the esophagus, talk a little bit about fistulas and TOFs, and talk about problems that occur in adulthood, some of the post-operative symptoms that occur in adulthood, reflux, difficulty swallowing, and I'll talk a bit about fixing and replacing the esophagus. So I'm an adult surgeon. I've not done a lot of pediatric surgery. When I was training, it was very separate. We did do basic pediatric surgery, very minor appendicectomies and such like. But by and large, my training's been 99% on adults. And towards the latter part of my training, it was very much specialized into problems of the esophagus and stomach, where I've had extra training. So I mainly treat patients with cancer, hiatus hernias and reflux, but because we work in a large hospital, because I took over some of the practice from Professor Derek Alderson, who had a big practice in treating patients with TOFs, some of the patients have carried over, and I've continued to look after them. And the other bread and butter of my work is gallstones and basic general hernias. The esophagus, a deceptively simple tube. If you look at it in a very simple way, it is just a tube, but actually looking in more detail, it's actually extremely complex how it manages to get food and water from the back of your mouth all the way down to the stomach. It's got a very complex nerve supply. Its contractions and movements in normal people are synchronized to allow that synchrony of the propulsion of the muscles as it goes down the esophagus. It's actually a fantastic organ, but when it goes wrong, it causes immense trouble. And the anatomy is very closely applied to the back of the airway, and that's why it's a very dangerous organ to operate on for the uninitiated. And when we do operations in the esophagus, we need to take particular care that we don't damage the back of the trachea, because the back of it doesn't form these rings. It's a membranous part which is very thin. What is a fistula? I often teach medical students, and I've got to get a way of getting it into their skulls what a fistula is. And I often use this analogy, which I'll come on to later. Any idea what the commonest fistula is in the world? Some of you have them, okay, and we'll come on to that later. Okay, but fistula is an abnormal connection between these two epithelial surfaces. In the case of the condition affecting some of you guys in the room is the TOF, where it affects the esophagus and the airway, and the fistula is that connection. The causes of fistula are many. I don't really deal with congenital fistula, because as an adult surgeon, they're already fixed by the pediatric surgeons. Much more common is either a recurrent fistula, because the operation's failed, or the fistulas are caused by other reasons. In my game, it tends to be surgery that causes it. When we do operations for esophageal cancer surgery and do a high join in the chest, often that join can fall to pieces and fistulate into the airway. It's a very devastating complication. There's other causes, such as rare infections, cancer itself, or trauma due to knife wounds or gunshot wounds. The commonest fistula in the world is probably ear piercings, okay? Which I notice some of you have, and that's how I get my medical students to remember it because they remember piercings. And if you think about it, there's two epithelial surfaces. So an abnormal connection fits that criteria. But of course, the consequences for a fistula between the esophagus and the airway is actually quite dramatic, okay? And that's why it's so serious. The airway is obviously meant to be very clean. It's not meant to have any secretions from the stomach or gastric juices going down or saliva. And that's why these connections can cause significant problems with cough, with chest infections, with pneumonia. And then eventually, if these occur and keep on happening, they can damage the lung and cause chronic respiratory compromise, bronchiectasis, lung abscesses, respiratory failure. And that's why the fistulas are particularly devastating. This is a diagram I got about the types of congenital TOFs. And it's been one of the first times I've studied this in a long time, since a medical student, because it doesn't really affect me. As I said, the patients I see have long had their fistula repaired and their esophagus repaired. What matters to me is how the pediatric surgeon did it, and that depends on how big the gap is between the esophagus, whether it's a very short gap and they can repair the esophagus together, or whether it's a longer gap and they have to use the stomach or even the colon to join that gap, and that makes much more importance to my world. And they're obviously graded into different types depending on the anatomy of the fistula as well, and these are some of the medical definitions of this disease. And the commonest type is an esophageal atresia with a distal fistula. And as I said, the treatment depends on various things. I think you may have heard from pediatric surgeons which know the treatment much better than I do. Where I get involved is where patients move on from the pediatric hospital and become adults. And this, to me, seems a very tricky time. Patients or family are obviously used to teams looking after them, the specialist nurses, the surgeon, and then they move from a very children-friendly children's hospital into a big, bad adult hospital with the waiting rooms crammed with people, maybe not getting the sort of love and attention they normally desire when they had with their pediatric experience. So it's often a very tricky time, and we try and smooth that out as much as we can, but it's a very, very difficult to do well. Going on to the problems that patients may suffer, acid reflux. Papers suggesting this affects to 25 to 60% of patients with TOF and manifests in heartburn, in regurgitation of stomach contents or bile. Volume reflux is when you bend over, tie your shoelaces, stuff from the stomach comes back on you. It can also manifest as aspiration, that is going down the wrong way, and obviously the chronic cough. Some patients have already had that treated to some extent with a fundoplication. And these are the various kinds of fundoplications that are performed. And this is where the stomach is wrapped around the lower esophagus to make a mechanical new valve to stop that from happening. And it can either be a full wrap, a Nissen wrap, which wrapped all the way around, or a partial wrap, or even a partial just on the front, just laid on. And we've seen a variety of those done in our patients. Often these don't work forever, and either the tissues fail as patients get older, or a bad retch or a bad cough can split the tissues, and the patient can get a recurrent hernia. And then we're asked to assess these patients to see whether we can revise the fundoplication and make it better, either using keyhole techniques or full laparotomies. Why does it happen more in TOF patients? Well, there's a variety of factors at hand. Clearly, having a very poor esophageal development predisposes to this. It means that the nerves never quite go down and form a full plexus that can make these proper coordinated contractions. That doesn't really happen. There's also the side effects of the surgery that may have been done to fix this area, in the fact that the operation to reconstruct it may have weakened the lower esophageal sphincter. It may have predisposed to hiatus hernias. And patients with TOFs are known to have poor gastric emptying. That is, the stomach doesn't empty as quickly. So if the stomach isn't emptying as quickly, the food just sits there and it predisposes it to reflux. So these are some issues I see with adult patients. Difficulty swallowing, medical word for that is dysphagia. This affects, depending what paper you read, 20 to 84% of TOF patients. And again, it can be due to a variety of factors, depending on the circumstances. Some of the joins that are performed in the pediatric era can narrow and form strictures. And often patients have had a history of getting lots of dilatations at the Children's Hospital, and we have to continue that on in adult practice, either in the endoscopy suite or if we can't manage it in theatres. If you get really bad reflux, it can start to erode your lower esophagus and cause burning inflammation, and that can lead to narrowings as well. And if the wrap, the fundoplication twists or anatomically isn't right because of wear and tear and age, that can also cause difficulty swallowing. However, even if it looks completely anatomically normal, the contractions just aren't there, and often in patients that we assess, and I've got some slides in this a bit later, have very little in the way of contractions. So I'm going to go on to investigations and treatments now that we do in adult practice. Probably the most common one is an endoscopy. This allows us to assess the esophagus and stomach in great detail. It's normally performed in the endoscopy suite using very flexible cameras. The technology for endoscopies come on over the last 50 years. They used to be very rigid, thick, needed a general anaesthetic. Now we have the standard endoscope is about 10 millimeters now, and we even have ones that are 5 millimeters and can be introduced through the nose for better patient comfort. Done under local anaesthetic spray. It can be diagnostic. If we see anything abnormal, we can biopsy, but it can also be therapeutic, and I'll show you some therapeutic ways of using the endoscope a bit later. I looked for some endoscopic pictures of TOFs, and I got these. Thankfully, we don't see this very often. This is a very large TOF, just there. And if it was projected better, you'd actually see the rings of the trachea through there. That one was actually caused by an ET tube. So if you have the misfortune to be intubated in ICU for a long time, the cuff of the ET tube to ventilate the lungs can cause a pressure necrosis and cause a large TOF. And that needs surgery to fix. That's very big. Whereas this one's very small and tiny, just connecting the airway. And that one's much more likely just to present with a recurrent cough because of the sort of saliva seeps out into the lungs. And patients can suffer with them for a long time and actually not know they have them until we do a thorough endoscopic examination. Other things we can see endoscopically. This is Barrett's esophagus. And this is when the cell type of the lower esophagus changes, and it changes in the response to reflux. We're actually seeing this a lot in the UK already. It's increasing in prevalence, probably due to weight gain. People are getting a bit fatter over the last 30 years. We're also, lifestyle issues are seeing lots of people reflux for a variety of factors, poor diet, diet high in calories. Also things like caffeine and chocolate can weaken the lower esophageal sphincter, make it much more prone for patients to reflux. And the cell type really changes to protect itself. So the normal cell type is this squamous cell, and it changes to this more intestinal type. And if this is diagnosed, it needs to be biopsied, and it needs to be kept an eye on with regular endoscopies, because it can and some patients change into precancerous states or even cancer if it's not picked up early. And the whole technology of treating Barrett's has changed in the last few years. If you have precancerous changes, that can be treated with something called halo, which doesn't involve surgery, but involves a balloon getting inflated in the esophagus to singe that off and reduce the risk of further cancer. This other image is reflux esophagitis. As you can see, the esophageal lumen is slightly narrowed, and then there's some erosions there. The acid is causing a sort of a chemical burn to the esophagus. And we can see that endoscopically. And often, both these conditions are treated with medication, such as lansoprazole or omeprazole, PPI-type medication, that reduces the acid in the stomach and stops acid damage. Endoscopic treatments have come on, and this is a dilatation. So if there's a narrowing at the anastomosis between two pieces of bowel that cause difficulty swallowing, we can dilate this using the balloon in the endoscopy suite or in the theatre. And this is a picture of a dilatation. As you can see, it's very narrow here. The balloon's passed, and then it's actually blown up to a diameter, depending on how big you want to go, and then the camera can go past after it's stretched. But as I said, endoscopic technology has actually come on fantastically in the last 30, 40 years. We're doing stuff endoscopically that we haven't even dreamed of. We can close small holes with endoscopic clips. These little clips get deployed through the endoscope. And there's actually been reports of very small TOFs being treated endoscopically. So the small hole is sort of cleaned out and rubbed, glue's applied to it, and then these clips sort of close one end. And there's been some variety of successes with that. There's also this bigger clip called an oviso clip. It's like a big bear trap, and it traps itself round things to close off holes. And we actually used that in the QE a month ago. There was a patient who developed not a TOF, but a hole between his esophagus and his lung space. And he wasn't very fit, and we tried our hardest to try and stop that and heal it up. And in the end, we used one of these big clips, and it sealed the hole very well, and it allowed him to get out of hospital eating and drinking. Sometimes we place stents to seal TOFs, not often in sort of benign cases, but when the hole is due to a cancer, which we see sometimes, or the treatment of cancer can sometimes involve radiotherapy, and that can make the fistula form, and we can treat that with overlapping stents, one in the esophagus and one in the airway. Slightly different to what you guys have sort of been more used to in terms of congenital treatment. There is this other device called an umbrella device, which we've thought about using for one of our TOF patients. We didn't actually use it in the end, but there's lots of case studies showing that it is possible. It's mainly used for cardiac defects, so patients that have holes in the heart between the chambers. Instead of getting surgery now, they're getting this umbrella device. It looks like that, and it effectively is passed through a wire, and one of these edges goes in one lumen, and the other goes in the other, and it closes the fistula. But we did discuss it, but we didn't use it in the end. But it's an interesting future development. It just shows you how endoscopic technology is moving on. Investigations, well, lots of patients need investigations. Some investigations include manometry, and manometry is all about the pressures of the gullet and how strong the contractions are and how the valve is at the lower end and the upper end. Often we also like tests on how much acid's coming up as well, and that's the 24-hour pH studies. So if patients come to me complaining these symptoms, I want to know whether I can help them in any way with surgery, we often get these tests. So this is the manometry. This is a catheter probe, and it's got pressure readings every centimetre or so, and it'll tell us the pressure of the lower esophageal sphincter, which is down here. and the upper esophageal sphincter, which is up there, and it shows us a pressure wave. So as I said before, the normal is a pressure wave starting at the top and pushing the food down in a synchronized fashion. And this is the acid readings on the other side. So a different probe is left in for 24 hours, taped to the side of the face. Patient goes home, does as much as they can normally, and we read the measurements of acid coming up the gullet. So this is a normal contraction, as you see, starting at the top, good pressure wave, pushing the food down, very strong, very coordinated, and at the bottom, the lower esophageal sphincter relaxes to allow the food through. We don't see that in patients who've had surgery for TOFs, I'm afraid. It's completely different, and this is what we see. We see a good upper esophageal sphincter, and we see nothing. We usually see aperistalsis, or if the patient's lucky, maybe just broken waves, but nothing really to push that food on, thus explaining why they get such problems with difficulty swallowing. We often ask for barium swallows as well. It's a fairly old technique, but it's good. It allows surgeons to see the images on the screen, and it allows comparison for the future as well. And this is a normal barium. The barium just highlights the esophagus, looking for narrowings. It can give a vague idea of how it contracts, but not quite as good as the manometry. That's normal. This is a patient I treated. Well, I'm still treating her actually. She had the misfortune to develop a narrowing late on in life, and she had a dilatation in another hospital, which sadly led to a split in her esophagus, and then the abscess perforated into her airway, and thus when the barium was given, the dye goes through the fistula here, which you can't see very well, but it goes into the airway. This is the airway here, and that explained why she was always getting nasty pneumonias and chest infections and horrible problems like that. The other hospital tried to stent her esophagus, but sadly the stent wasn't good enough, and the dye just went past it and caused recurrent pneumonias anyway. So I was asked to see her and treat her, and we did a staged procedure, like I gather is often done in pediatric practice for some reason, where we bring the esophagus out to the neck as an esophagostomy, which is a horrible thing to do to somebody. And we did that to her, and it stopped all her pneumonias, stopped her chest infections, allowed her to gain weight because the recurrent pneumonias were causing a septic response. She was malnourished, she was unwell, and then 6 months later she was well enough to get a reconstruction, which I did a few weeks ago. And that's an esophagostomy. If we ever do it in adult practice, we try and get the esophagus on the flat part of the chest wall, because the bags stick better, it's better for patients. Thankfully, we don't do that very often. Moving on to revisional surgery, in my part of the world, we've seen more patients have had the colon used to reconstruct for TOFs, and we've seen a few patients have had this procedure carried out when they're young. Obviously, the gap's much longer, and the surgeon at the time decided to do a colonic interposition where a piece of colon is used to replace the esophagus. And we've treated several of these patients at the QE. This is one lady who had her operation done by Ronald Belzy, who was the surgeon who pioneered this approach. And she had a temporizing procedure, an esophagostomy, an abdominal feeding tube, and then later, when she was well enough, reconstructed with the colon. And there's two ways to use the colon. You can either use the left colon. It really relies on the blood supply. So when you do these operations, you have to assess the blood supply and choose the right piece to go up and replace the esophagus and join the top part to the esophagus and the bottom part to the stomach. It is quite a complex operation, and the colon's joined to the colon together. It's unusual to need a colostomy for this operation, but it can sometimes happen. So this is the left side, that blood supply supplies the colon. On the right side, it's this one, okay, and it goes up there. This operation won't last forever, sadly, and it often dilates and stretches over time, and patients develop problems with difficulty swallowing or regurgitation of food. And this is what happened in this lady that was referred to us that had her surgery in Bristol 46 years ago. The colon just slowly dilated, and it formed this big kink at the bottom. So the food just used to sit there, and then it would come up, and she was having horrible time with that. That's another view showing it coming down, just sitting at the lower, and really struggling to get out again to the stomach. And this is further views where the kink's up here, and it eventually gets round into the stomach here. Okay. It's quite good to get a barium for that reason. So for her, we did revisional surgery, which was very complex. And it was done about 3 years ago. I got Derek Alderson, the old professor, back from his retirement to help me do this operation, because he's the only one that had much practice in it. And we did it through the left chest. We did a left thoracotomy and an abdominal approach to do the operation. And what we did is we took a piece of that piece of redundant colon, we resected it, flush to the vessels, so the vessels weren't interrupted, and then rejoined it to the stomach. So this is the sort of final result, much straighter. Obviously not perfect, and there's nothing that will perfectly replace the esophagus, but she was much better after that. She didn't have any regurgitation, she didn't have any dysphagia. So I'll probably finish there and say that there's a lot of ongoing symptoms in adulthood from the TOF patients who come through our hospital. The investigations are complex, and it really does require individualized assessment and treatment. There's no one size fits all. Everybody's very different, and they have to be assessed very thoroughly and carefully. And it may be in the future we can grow a new esophagus. I saw this in the BBC a few years ago. They'd grown it in mice. People keep on asking me about that, but it's nowhere near clinical practice yet. But perhaps, you never know, who knows. Thanks for having me.
Thank you, Ewen. That was really nice talk.